السلام عليكم ورحمة الله وبركاته. ازي حضرتك يا إيهاب؟ احنا كده جاهزين إن شاء الله.
Salam. Okay. Uh, Bismillah ar-Rahman ar-Rahim. Today we'll continue our series of discussions, case discussions through MCQs, index of suspicion or visual diagnosis. And the goal is to get trained on how to do a smart clinical thinking, smart approach to differential diagnosis and actual diagnosis. Cases might be easy, might be hard, but this is not the point. The point is to get trained on the smart clinical thinking and smart clinical approach. And also the critique in the MCQs is very rich in information and data that we'll never find in any other reference or textbook or videos or whatever. So this is the goal behind all these series of presentations. I need a favor from you. Please don't use Google or AI, because if you do that, you will not get any benefit from our discussions and presentations. You will lose the benefit of trying to get the clinical approach and smart thing. So we'll start with the MCQs. Okay, we'll start with this question. It is an easy one. And if you attended the last lecture of Dr. Manal Sayed about newborn skin rash, you will be able to understand what's going on with this MCQ. Dr. Manal, are you with us today? I hope you are with us because this is in the area of your expertise. So this is the question. Don't know how to get rid of this window. Okay. If you look at this picture, what is your initial differential diagnosis? What do you think this mass is? Before we go into the details of the scenario and go to the vignette in this MCQ, what do you think this mass is? What
ممكن
is
هي inflammatory أو تبقى trauma أو tumor.
Okay, good. If it's inflammatory, what is the underlying pathology? Like abscess or infection? Okay. Infection of what?
ممكن الجونوريا
أو staph
أو
epidermidis.
No. Infection of what structure? Infection. What?
ممكن تبقى الأي أو
Do you think this mass at the inner
lacrimal gland
eye, is it part of the eye?
لا ما هي فعلا ناحية اللاكريمال جلاند، هي في الانر ابيكانثس كده، واخدة حتة من الابر ابيكانثس مثلا عاملة.
You think it's related to the lacrimal system, so it could be a dacryocyst, dacryocystitis. Yes, this is a very good possibility. What else?
encephalocele.
Encephalocele. Correct. Great. This is a very, very good differential. What else?
ممكن يكون anomaly blood vessels عشان هي pulsatile كمان، فهيمانجيوما مثلا أو كده.
ما قريناش ان هي ستايل، احنا بنقول just the picture. It could be
بس without الكلام يعني.
malformation or hemangioma, or it could be hemangioma. Could be hemangioma. Okay. What else? Could be also a dermoid cyst. So a term newborn has a bluish, soft tissue mass. Look at the keywords. Soft tissue mass at the medial aspect of the nose, close to the medial canthus of the left eye. There is no eye drainage. This is a very important keyword because it will help exclude one of the diagnoses we mentioned. When the newborn cries, the mass pulsates. This is a very, very good keyword. It will help you to reach the diagnosis immediately on clinical basis. And it pulsates and increases in size when the baby cries. The mass is soft, reducible, able to be trans-illuminated. So, based on this information, what do you think this mass is? Is it a dermoid cyst, a frontoethmoidal encephalocele, a nasal hemangioma, a nasolacrimal duct mucocele, and why? When you choose A, B, C, or
nasal
D,
hemangioma عشان pulsatile.
nasal hemangioma because it's pulsatile, and why it increases with in size why it pulsates and increases in size with crying. Does the hemangioma do that?
لا في الأغلب انكفالوسيل كده.
So it is not a nasal hemangioma. Is it a dermoid cyst? Yes or no? And if yes, why?
ما فيش عشان مش هتبقى مش هتبقى ترانس illuminated يعني هيبقى فيها structures جوه.
Should not be pulsatile. It should not trans-illuminate. Should not increase or change in size with crying.
شفت كمان.
Is it a nasolacrimal duct mucocele?
برضه the same ان هي مش تبقى pulsatile مش تبقى trans illuminated مش هتبقى increase in size while crying.
There is important keywords in the scenario that excludes the nasolacrimal system, which is there is no eye drainage. Because if it is in the nasolacrimal system, there should be excessive tearing, which is not the case. So let's go to the correct answer and to the critique. Everyone is allowed to ask questions and to comment at the end of each case. So keep your questions and comments. And once we're done with every and each case, you can have your questions and comments and we can discuss it. Okay. It's a frontoethmoidal encephalocele. And this area, you can have many types of encephaloceles, and they are divided into anterior and basal, and each one has different presentation and prognosis and management. So this is a frontoethmoidal encephalocele. We know that at this area we have the frontal bone and the ethmoidal bone inside. So it is between the frontal bone and the ethmoidal bone. Is a type of anterior encephalocele because we have basal encephaloceles, and we are going to see the difference because the differential diagnosis between and the differentiation between them is extremely important, as we are going to see in a table later. It is located in midline between the frontal bone and the ethmoid process, typically manifesting as a nasal broadening, blue pulsatile reducible mass near the nasal bridge that can be trans-illuminated. So the clinical description is very, very diagnostic in this case. So it is not a difficult case, it's an easy case, but let us discuss the critique, which is very, very informative. Unlike basal encephaloceles, so this area, this area of the face and skull, you could have either anterior, presenting anteriorly or basal going down, and the basal is more serious. Why? Because it can go down in the nasopharynx or oropharynx and cause an upper airway obstruction, and the baby could present with respiratory distress. Critique. The neonate in the vignette has a bluish, soft, pulsatile mass at the medial aspect of the nose, close to the medial canthus of the left eye. The mass is reducible, can be transilluminated. There is a positive Furstenberg sign, which is the Furstenberg sign is enlargement of the mass when the baby cries, meaning an intracranial connection. So that's why this mass was pulsatile and increasing in size when the baby cries, because there is an intracranial connection. And this was the key word that will diagnose this case. These findings strongly suggest a diagnosis of frontoethmoidal encephalocele. Encephalocele is a congenital type of neural tube defect in which a sac containing brain, meninges, and cerebrospinal fluid, because of the bone defect, and encephaloceles are named according to their positions in the skull. They are either in anterior or basal. Let us go to the table and see the classification. So, classification of frontal encephaloceles according to their location. They are either frontoethmoidal or basal. And we don't need to go into the details of the anatomy, but you have to know that at some point when I send these MCQs to you. It's either nasofrontal, nasoethmoidal, like the one we have in this case, or nasoorbital. So the nasofrontal will appear on the forehead related to the nasal bridge. Nasoethmoidal, like this case, nasal bridge. And the nasoorbital will go inside the orbit. Basal encephaloceles are, depending on their position, are either trans-ethmoidal, sphenoethmoidal, trans-sphenoidal, sphenomaxillary, and this is the site where they herniate through. And this is how they present, either intracranial, like intracranial mass, the trans-ethmoidal. The sphenoethmoidal will go to the nasopharynx, and this could be a cause of feeding difficulty, upper airway obstruction, respiratory distress, the same with the trans-sphenoidal. And this one, sphenomaxillary, will go to the pterygoidal, pterygopalatine fossa. So, a frontoethmoidal encephalocele is a subtype of anterior encephalocele, as we saw in the table, located in the midline between the frontal bone and the ethmoidal process. It typically manifests as a nasal, broadening, blue, pulsatile, reducible mass near the nasal bridge that can be transilluminated. They can also be present at the glabella and at the forehead. Frontoethmoidal encephaloceles tend to enlarge with crying or with the Valsalva maneuver in the older children, and because of compression of the jugular vein. They usually do not cause airway obstruction, unlike basal encephaloceles, which are serious and they can herniate into the nasal cavity, protrude to the oropharynx and nasopharynx, and this could be a cause of respiratory distress apnea in a newborn, and you don't know why. And you do an X-ray, the baby looks fine. It's not quenal atresia, but when you dig more and more deeper, you will find that there is a mass in the nasopharynx or oropharynx. With the encephalocele, MRI of the brain demonstrates a soft tissue mass in connection with the subarachnoid space. Encephaloceles can rupture. So let us see what are the possible complications. What are the possible complications? In addition to the airway obstruction for the basal encephaloceles and upper airway obstruction and feeling issues, they could have other complications, like they could rupture, resulting in CSF leakage, which could present as rhinorrhea and could open a pathway for infection, meningitis, abscess. Rupture increases the risk of developing meningitis and abscess formation, something serious. Treatment is surgical and preferably performed soon after birth. So the sooner the better, to allow for the appropriate development of the brain, correction of any facial abnormalities, and reduction of infection. So this is the encephalocele. What about the nasolacrimal duct mucocele, which is the cryocystocele? It typically presents with a bulge in the lower medial canthus of the eye and is associated with epiphora, which is excessive tearing, which is not the case in this baby. And this absence of epiphora ruled out this diagnosis, as well as a point of drainage of exteriorization of mucus, as we can. This is a case of dacryocystocele. This type of mucocele can extend inferiorly, invading the nasal cavity and causes any respiratory distress also in the newborn. It is usually treated with endoscopic marsupialization. It's the ENT problem. The newborn in the vignette does not have the epiphora, nor does the mass have a point of drainage, which makes the mass unlikely to be a nasolacrimal duct mucocele. Dermoid cysts. Dermoid cysts are the most common midline congenital craniofacial abnormality in children, period. So if you have a mass, midline mass, usually number one is the dermoid cyst. These cystic lesions present as firm. This mass was soft. Non-pulsating, this mass was pulsating. Nodules that cannot be transilluminated, this mass was transilluminated. They may or may not have a sinus tract that can be visible as a small opening at the midline. They may increase in size over time and can often distort the contour of the nose, broadening the nasal bridge. Discharge of sebaceous material is common and the lesion resembles a furuncles, but it is not an infection. If the lesion is untreated, complications such as local abscess could be infected, midfacial cellulitis, which is serious, osteomyelitis, more serious, can develop. Complete surgical excision is a successful treatment. The mass in the neonate in the vignette is soft, pulsatile, can be transilluminated, making dermoid cyst unlikely. Then we come to the last possible differential diagnosis, which is a hemangioma. Although hemangioma is a common disease of the head and neck, it's rarely found in the nasal cavity or sinus. Nasal hemangioma is a benign tumor of vascular origin. So we have to differentiate between two problems, the hemangioma and the capillary malformations. The hemangiomas are considered to be a tumor of vascular origin, and it can be divided into either capillary hemangioma, cavernous hemangioma, mixed types. Its location is usually at the anterior septum or at the inferior or middle turbinates inside the nose. The location causes unilateral nasal obstruction and epistaxis. Yes, if you have a baby who has bleeding from the nose that does not seem to stop easily, and there is nasal obstruction, you think of nasal hemangioma, among other differential diagnoses. Unlike a frontoethmoidal encephalocele, a nasal hemangioma cannot be transilluminated. And treatment is complete surgical excision because we use topical beta-2 blockers when it is in a safe side. But if it is in this dangerous area, we have to do immediate intervention through surgical removal. Okay? So we ruled out hemangio. And this is the table we discussed. Okay, now let me see your chats, comments, questions. Dr. Ahmed, to everyone. Prof. Marwa Farag, to everyone. I don't know what does this mean. Okay, if you have a question, you can vocalize it now. Go ahead. Or you have a comment. الصورة غير مكبرة. No, the surah is very مكبرة. Who said that? صورة مكبرة. اهي عايزين ايه احسن من كده؟ اهي. No, it is surah is مكبرة. غير مكبرة. MIC available to attendee take care ready. I don't know what is this. Duct. Lacrimal, duct. Okay, so you don't have any questions or comments? Can we proceed to the next MCQ? Let's go. Okay. An infant is born at 37 weeks to a priming mother via C-section because of breech. On the second night after birth, the mother asks for the nurse because the infant slipped from her arms and fell onto the floor while she was breastfeeding. So this mom delivered by C-section. She was still under the some effects of anesthesia and on pain medications. She's a little bit drowsy, and during the night, the visualization of the room and whatever in the room is not that clear. So while she was breastfeeding the baby slept. This scenario is not uncommon, by the way, and it can happen, and it could be very serious. It slipped for the baby slipped for her arms and fell onto the floor while she was breastfeeding. On examination, the neonate is irritable. Irritable. This is a key word, important key word. And irritability in this case could be due to what? What makes this baby irritable? What are the possibilities this baby could have making him or her irritable? Any hints?
Intracranial hemorrhage.
He could be having intracranial problem. Yes. What else? Or a fracture anywhere. Yes. Any fracture, intracranial hemorrhage, or just trauma to any part of the body. If somebody punches you or gives you a hit and causes trauma, it will be painful. So on examination, the neonate is irritable, but has no overt signs of injury. There is no bruising, there is no evident fracture, either to the head or to the body. Of the following, the imaging study most indicated for this neonate is, if you have this baby in your NICU or in your well baby nursery, what do you do imaging wise? You did a careful examination, baby is irritable. So what are other imaging studies you need to order now? Any suggestions? CT of the head. It's a very good cranial ultrasound. What is the advantages and disadvantages of cranial ultrasound in this case? If you do cranial ultrasound, yes, it's a good possibility. It's a good choice. How it's going to help and what is going to miss? Actually, cranial ultrasound is very sensitive and the gold standard and the imaging study of a choice when there is intraventricular germinal matrix periventricular hemorrhage. But otherwise, it is not a good choice, especially if there is a fracture or subdural hematoma. It's not a good choice. CT is a very good choice. But what is superior to CT?
الMRI.
MRI. But usually MRI is not feasible and ready in most of the hospitals. And usually preparation needs time and the baby needs to be well sedated. It needs a good preparation, but it is a more diagnostic and does a less radiation exposure. I see here some mentioning of X-ray of the skull. What is the value of the X-ray in this baby? The X-ray will diagnose maybe fractures, but otherwise the X-ray is useless. It cannot diagnose intracranial hemorrhage, hematoma. So it is not a good choice. So now we are left between ultrasound, CT, MRI. So if you're going to choose one of the three, which one you think is the more appropriate and more helpful in the diagnosis and observation of this baby? The CT, yes, correct. Cranial CT. So this question is easy and but it deals with a problem that is not uncommon. So cranial CT, cranial ultrasound, skeletal survey, skull radiograph. Skull radiograph, it's not the imaging choice. Why we might think of skeletal survey? If this baby was like born at home and parents are teenagers, there is a history of drug intake and there is history of psychological disturbances and house abuse, domestic abuse. When you think of skeletal survey, yes, to rule out child abuse, which is not rare, by the way. Usually, there is a couple, not married. I'm talking about here, not in Egypt. Not married, teenagers on drugs, and the mother gets pregnant, and she delivers a baby. Baby's crying all the time, and the dad, who is a teenager, is not happy with the crying of the baby and taking the mom from him, so he might do child abuse. What is the triad that through which you diagnose abuse? Because diagnosis of child abuse or infant abuse is not easy. There is a triad. I know this is outside the scope of this question, but it is important for general pediatricians. What is the triad of child abuse or baby abuse? It is fractures, retinal hemorrhage, intraventricular hemorrhage. And then you can have other signs like ecchymosis in areas that is not explained by trauma or I mean like usual trauma, and fractures in unusual sites. So we are going to do CT. Let's COI. A newborn who has fallen needs to be monitored. So you have to monitor this baby, regardless of the injury, even if the examination is benign and you don't check any abnormalities, and should be monitored at least 12 to 24 hours, at least, before you send this baby home. And monitoring is cardiorespiratory monitoring. You check the heart rate, respiratory rate, you check the oxygen saturation, blood pressure, because the early signs of bleed could be tachycardia. Signs of increased intracranial tension could be slow heart rate, slow respiratory rate, or even apnea. We call it virtual triad. Okay, after a newborn fall, cranial CT may be indicated to exclude intracranial bleed and or skull fractures. Critique. A newborn fall is defined as, there is a definition for a newborn fall and a newborn drop. I didn't know about that before. A newborn fall is defined as a sudden, unintentional descent with or without injury, resulting in a patient's landing on the floor, as in we have in this vignette, another surface, maybe from the bed to a table, or some surface on the above the ground, a person or an object. Okay. A newborn drop is defined as a newborn falling while being held or carried by a healthcare professional, parent, family member, or a visitor. The overall incidence of newborn falls is estimated to be between 600 and 1,600 events per year in the United States. It is not a low number. The majority of newborn falls occur during night time because of the vision is not that appropriate. During feedings, because the baby might spend some time on the breast and the mom will go into a nap because she's very tired and she's on medications. Or, yeah, and she's sleep deprived. So during feeding, secondary to parents falling asleep. Several reports note that an intervention by a member of the hospital staff prevented an infant from falling when the mother was found sleeping while holding or feeding the baby. So when the baby is even in the well baby nursery with the mother, the nurse should check on the mother and baby every now and then, because she might be able to prevent a fall if the mother is falling asleep. So don't let the baby with the mother in the room and say, okay, baby is safe. No, baby is not safe. Risk factors. What are the risk factors for a fall? First time motherhood. Mom doesn't have a good amount of experience. She doesn't know how to hold the baby. I see mothers scared of holding their babies. C-section, because the mom in the C-section will take anesthesia and will be in pain and will take pain medication. Maternal pain medications used in the preceding 4 hours. Maternal exhaustion, which is very common. Delivery is not an easy task. Mothers are exhausted and suffer a lot. Second to third postpartum, yes, the second or third postpartum night. Early morning hours, breastfeeding. Although exclusive breastfeeding and skin-to-skin care are encouraged, oxytocin released for letdown and milk ejection can lead to relaxation. So the muscle of the mom are relaxed and she doesn't recognize that, and the baby might slip between her arms, from her arms, and because of excessive tranquility in the mother. Environmental factors include unfamiliar hospital, lighting at night, tripping hazards, كعبل في أي حاجة, placement of hospital equipment, and hard floors. Additionally, parents may not be aware of the newborn fall risk while the mother is recovering from the childbirth. The majority of newborns who fall experience minor injuries such as bruising, abrasions, contusions, or lacerations. All these information are based on statistics. And this part of medical statistics is very lacking in Egypt. Because in USA, they report everything. And they like numbers for everything, for every event, for every change. And they use it. And based on that, they have guidelines. And they have statistically based in guidelines for taking care of any patient. They are also at risk for experiencing skull fractures and or subdural hematoma, which is serious. Indications for evaluation with what are the indications? Vary among institutions. They include, using the CT, they include abnormal neurologic examination findings, hematoma, fall onto a hard surface, and unwitnessed trauma. Of course, if you have rapid MRI, it's more superior, but it is not easy to find in every situation. Regardless of the injury, the infant needs to be monitored after a fall for at least 12 to 24 hours, and then additional evaluations based on the condition of the baby. Because this baby was irritable, so CT was indicated. Okay? I'm going to stop at this point. Any questions, comment regarding this MCQ? Dr. Marwa, how often do you see babies who fall to the ground, to the floor, or to
ممكن مرتين في السنة مثلا، مرتين في السنة في الغالب. اللي بيبقوا presented بintracranial hemorrhage بيبقوا hemorrhagic disease of newborn، لكن تروما ممكن مرتين في السنة.
Okay, so our Egyptian newborns are very tough and they can even withstand falls or trauma. Okay.
او ما بيجوش بيه يا دكتور، يعني ممكن ما يكونوش بيجوا بيه الشاب، ممكن يكون بيعدي مرور الكرام فبيروحوا بيه اي حد قريب منهم وخلاص، لكن ما بيجوش بيه
That
الشاب
is not
يعني.
documented and you don't have enough numbers to evaluate the situation. Okay.
Yes.
Okay. I thought this might be interesting for you. Another MCQ. Back again to congenital syphilis, because it's that's congenital syphilis or syphilis in the USA is on the rise. I don't know about Egypt, but you should think of congenital syphilis among other causes for in your differential diagnosis for many presentations. So a pregnant woman has a rash, fever, malaise. She is undergoing evaluation at 22 weeks gestation. This was her initial prenatal visit. And luckily enough, she was symptomatic. And they did fetal ultrasound. It revealed pleural effusions, hepatosplenomegaly, ascites, pericardial effusion, increased middle cerebral artery, increased middle cerebral artery peak systolic velocity, and placentomegaly. So what do you think this fetus has? Pleural effusion, pericardial effusion, hepatosplenomegaly, ascites. So we have excessive fluid accumulation abnormally in three sites. So what is this?
Hydrocephalus.
Correct. This is hydrops. This is a fetal hydrops, which if not treated, it will be. And we discussed fetal hydrops before, and we divide it into immune and non-immune. Okay, what is the significance of increased middle cerebral artery peak systolic velocity? What does this mean? How you translate this? Yes, anemia. Anemia, yes, which might be severe. So this question is about anemia in congenital syphilis, anemia in congenital syphilis presenting with hydrops. Prenatal testing reveals a positive rapid plasma RPR screening result with a ratio of, in USA, every and each pregnant woman should be tested for syphilis. And they do the testing at the initial prenatal visit, and then they follow up with following visits. And even if the mother presents at delivery, they also check it at the time of delivery, because diagnosing syphilis during pregnancy is very important, because it will prevent or treat congenital syphilis in the fetus. So in this lady, she tested positive for RPR test, and positive also for positive for fluorescent treponemal antibody absorption test. In diagnosis of syphilis, we have treponemal test, non-treponemal test, and both depend on checking antibodies, either directly against the treponema or non-treponemal test antibody simulating the syphilis antibodies. And it started benzathine penicillin gene. The treatment, there is only treatment, one treatment for syphilis, whether congenital or acquired, it is penicillin. Unfortunately, there is no other treatment. And it's either benzathine or procaine. And when you have a baby with congenital syphilis, you give either benzathine penicillin 1 dose, or you give procaine penicillin for 10 consecutive days. And if you miss a day, you have to start from day 1 again. Okay, we have some discussions about the congenital syphilis, but the question is, of the following, hydrops in this fetus is most likely explained by why this baby had hydrops. Because the gestational age at the time of fetal exposure to syphilis was 22 weeks, meaning if the mother developed syphilis or had secondary syphilis that has spirochetemia during late or some other gestational age, that the hydrops may or may not be developed. Maternal response to syphilis treatment. If the mom receives benzathine penicillin and the response is good or bad, this is going to be reflected on developing hydrops. And mom was treated after the baby had already hydrops. So I don't know what is this choice is not there. Maternal stage of syphilis. We know that syphilis could be primary, secondary, and then latent period, after which there might be tertiary. We don't see this in the newborn babies, but we see it in adults. So if the mom is like in primary stage, secondary stage, latent period, tertiary stage, this is going to be reflected in the development of hydrops. This is the question, number C. Or severity of fetal anemia, which was detected by increased middle cerebral artery peak systolic velocity. So what is your choice, A, B, C, or D, and why? D, 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 D. Okay, everybody selected why.
Anemic heart failure.
So this baby, if he's is having severe anemia, there will be heart failure, hepatosplenomegaly, will be accumulation of fluid, anasarca in every space in the body, pleural effusion, ascites, pericardial effusion. So anemia is the explanation and the cause of hydrops. So the degree or severity of anemia will determine the development of hydrops. Okay, this is a good choice. Let us have some information about congenital syphilis. Congenital syphilis occurs because of infection resulting from either transplacental passage of Treponema pallidum, which is the most common cause, or exposure to syphilitic lesions. She has chancre or genital lesions in her genital tract during delivery. In this condition, of course, it happened transplacentally, and it was very early. In some fetuses infected with syphilis, erythropoietic suppression. Yes, what is the cause of anemia in congenital syphilis? Is it hemolytic? No, it is bone marrow suppression, erythropoietic suppression. And that's why we have non-immune mediated anemia, which causes non-immune hydrops, secondary to heart failure. Okay, critique. In the United States, rates of congenital syphilis have steadily increased. It's on the rise over the past decade. This is commensurate with an increase in syphilis infection in the people of reproductive age. Syphilis impacts 1 in every 1,300 live births in the United States. This is a very, very high number. In 2021, there were 77.9 cases of congenital syphilis per 10,000 live births. In most US states, routine serological screening for pregnant person occur at the first prenatal visit. I don't know what about the situation in Egypt, but Dr. Marwa, I think we discussed this before. And
Yes.
I think that the labor and delivery guys in our shot beat, I don't think they are on this routine. Correct me if I am wrong.
يعني النسبة عندنا قليلة جدا يا دكتور، يعني حتى suspected cases ما بتطلعش positive
No, I'm talking about the routine serological screening for pregnant women for syphilis.
هو يعني أنا لما حضرتك سألتني سؤال ده وأنا جاوبت حضرتك إن نيجاتيف يعني ما بيعملوش، أنا رحت المعمل بتاع النساء تاني يوم ولقيت إن هما حاجة كويسة يعني إن هما مدخلينه في المعمل بتاعهم بتاع النساء بقالهم كانوا ساعتها 3 شهور، فاحنا كده تقريبا بنتكلم حوالي سنة التحليل ده موجود. أي دكتور في قسم النساء بيطلبه الحالة بتنزل بتعمله في الدور الأول في قسم النساء، هو وكل الفيرولوجي من يعني
It's not for
بتعمل.
each pregnant woman. It is for some selected case.
If the obstetrician requested the test.
Oh, okay. And then they repeat again between 28 and 32 weeks of gestation and at the time of delivery. This is the routine in USA. Screening entails an initial, we have two types of tests. Non-treponemal antibody test, which is the VDRL or RPR. And these tests that are differ from the treponemal test in many aspects, including that when the mother is infected, they become positive. When the mother is treated, they become negative again. The other tests, the treponemal antibody tests, once positive, they are positive for good. So we have two schools. First school either do the non-treponemal test, and if it's positive, they check for the treponemal test, or the other school do the other way around. So what happens in syphilis? In primary syphilis, there is a painless chancre appears at the site of inoculation with the spirochetes in the genital tract, but it may be unnoticed, may go unnoticed, especially in the female. In the male, it will show up. In the female, it will, most of the time, it go unnoticed because it's inside. The lesion typically resolves after 4 to 6 weeks, even without treatment. And then comes the second stage, which is syphilis, which is secondary syphilis. Presents with more systemic signs and symptoms such as alopecia, whatever. This is the symptoms in adults. And these signs and symptoms resolve within 1 to 6 months, and then the patient will go into a latent period, which might take years. And then tertiary stage is very serious. There is granuloma in the central nervous system, in the cardiovascular system. We don't see this as neonatologists. But in the primary and secondary stages, both can cause congenital syphilis because there is spirochetemia in both conditions. Okay. Congenital infection, either transplacentally, which is the most common, or during passage in the birth canal during delivery. And the transmission rate is high in untreated primary and secondary syphilis, up to 60 to 100%. Earlier in the latent phase, there could be also within the first year, there could be a transmission 40% if the mom is untreated, and less than 8% during the latent phase, the rest of the latent phase. So ultrasonographic evidence of syphilis infection in the fetus, if present, as we saw in this baby, will not be observed before 18 weeks. Before 18 weeks, the immune system is not enough to respond to the infection, so the fetus will be asymptomatic. But after 18 weeks, if the mom is infected, the baby will start to show those signs in response to the spirochetes immunologically. Findings may include hepatosplenomegaly, microcephaly, dilated or echogenic bowel, the signs that we saw in this baby, okay? And we come to our question. In congenital syphilis, hydrops is associated with the severity of fetal anemia. And the anemia is due to bone marrow suppression. It is not immune. And based on the degree of anemia, there will be hydrops secondary to heart failure. And the treatment is penicillin. If it is diagnosed during pregnancy, mom should receive treatment, penicillin. If diagnosed after delivery or at the time of delivery, baby should be screened and should be evaluated and treated with penicillin. And we discussed the clinical manifestations, and I usually repeat this sentence that congenital syphilis can cause severe pain and irritability in the newborn baby, and it could be even the only manifestation. And it is, once you touch this baby, the baby will cry. And because it is secondary to periostitis, chondritis, metaphyseal lesions, so the bone and surrounding structures are affected, and the diagnosis by X-ray is pathognomonic. Question? Any questions? Comments?
دكتور في حد بيسأل سؤال.
اتفضل.
أيوه هو كاتبه في الشات.
Chat. Okay.
آه.
Let me see the question. Thank
آخر
you so much. If the mother had syphilis and TTT, what is TTT?
treated
Huh?
أعتقد يقصد treated and was treated
And
أعتقد.
what was TTT means treated? Which test to do for the newborn, especially? Oh yeah, you will do the same. Yeah, this is a good question. When you have a baby suspected of congenital syphilis, you have to repeat the same tests done to the mother, and you do it on the blood and on the CSF. And you compare the titer in the baby and in the mother. If the titer in the baby is fourfold or more compared to the maternal titer, this means the baby was infected and you have to start treatment. And if you have if it is positive in the CSF, means this baby could have syphilis also among the congenital syphilis manifestations. And as I said, the treatment is either benzathine penicillin, 1 dose, or procaine penicillin, 10 days. And if you miss a day or a dose, you start from day 1 again. Okay?
تمام دكتور، يعني هو كده بيدور على الانتي
Yeah,
بودي
if the mom was
تيتر.
treated adequately during pregnancy and with enough time before delivery, the baby will be cured. The fetus will be cured. So this mother this baby who had high drops, if mom was treated adequately, the hepatosplenomegaly, the anemia will resolve, and the high drops might resolve. I think this was your question. Okay. Yeah, if you treat the mother, the baby most of the time will be safe. But even if the mom was treated, you have to test the baby. You have to evaluate the baby if the baby has congenital syphilis or not. Any other question or comment?
إيهاب، مساء الخير يا إيهاب.
اهلا، ازيك دكتور محمد؟ زي حضرتك.
بص، أتذكر حالة شفتها من سنين طويلة with multiple joint swelling، والدكتور لطفي الأدور علمني حاجة، قال لي لما تشوف حالة فيها أكتر من joint swelling أو بولي أرثرايتس دي فكر في سيفيلس على طول. وبالفعل الحالة دي عملناها، كان دكتور أبو صين عملنا لها يعني تيست وطلعت فعلا سيفيلس. مش قادر أقول لك أتذكر بالظبط كان إيه اللي عملناه يعني، بس اخدت علاج واتخيل او حسب ما انا فاكر عدت البيبي يعني بقى كويس يعني.
افكر حضرتك برضو بحاله الدكتور عبد الحليم بدر الدين الله يرحمه. اكلنا عليها في الدور الرابع.
ايوه.
ان جات له ست لسه يعني نيو بورن recently delivered.
أيوة.
And the complaint was that the baby was crying all the time, excessive crying. You cannot touch the baby. And once you touch the baby will cry. And Dr. عبد الحليم, you know, he was very eminent. عمل ايه؟ بعته للدكتور مظلوم الله يرحمه. دكتور مظلوم عمل له اكس راي.
ايوه.
هو عملوا skeletal survey. We don't know, they didn't know what's going on. And دكتور مظلوم diagnosed congenital syphilis x-ray. And the problem was that I don't know how did Dr. Abdul Halim Allah yarhamu behaved with the family, because the story was that the father was a sailor. And he used to travel abroad, and he got infection, and he gave it to his wife. ما اعرفش الحكايه دي خلصت على ايه، اتطلقوا اتقتلوا ما اعرفش، لكن this was very very educational.
وبرضه الحاله بتاعتي برضه اللي كان لطفي الأندور الله يرحمه برضه قال لي اكثر من جوينت في نيو بورن في النيونيتال بيريد فكر في سيفلس. ما اعرفش رايك ايه، انت رايك؟
Yes sir, yes I agree 100%. Yes.
شكرا دكتور إيهاب، شكرا. Thank you very much.
ألف شكر. Now we can move to some cases, either index of suspicion or a visual diagnosis. And okay, we still have, we spend 1 hour and we still have between 30 minutes and 1 hour based on your interest. So I wish Dr. Manal Said will be with us today, because this case and the second case are in the area of her expertise. And if you attended last lecture about newborn rash, these cases will be very easy for you. So, case presentation. This is a girl born at 38 weeks, around 38 weeks. And they noticed vermian hypoplasia. Oh, no, sorry. Mom had vermian hypoplasia and, sorry, no, the baby. Ultrasound showed vermian hypoplasia of the vermis of the cerebellum. So the case was very suspicious from the get-go during delivery. And mom has Beckwith-Wiedemann syndrome, which I don't think related to this condition. What is the presentation? What is the main presentation? Erythematous, blanchable. Blanchable means when you press, the color will go away. Left-sided facial patch in the distribution of the branch V1, V2 of the trigeminal nerve, the frontal and the maxillary branches of the trigeminal nerve, with a clear demarcation of the midline. This is the lesion. This is the lesion. So when you see this lesion, what is your first differential? This is the key point in this case. It is either one of two. What are those two? لو الدكتورة منال معانا مش معانا للأسف. No, the Sturge-Weber is not a diagnosis of the lesion. I'm asking about the lesion, sir. ما تقوليش Sturge-Weber. I'm talking about the lesion. Be specific. When I ask you your name, you tell me my name is Fulan. Don't say I'm from Alexandria. So what is the lesion? It's either one of two. What are those possible two? This is my question. Yes, hemangioma or Port-Weinstein. Great. So it's either abnormalities, capillary abnormalities, or the capillary hemangioma. So based on that, you will think of, what if it's Port-Weinstein? What if it is hemangioma? Here comes the Sturge-Weber, sir. Okay, here comes the Sturge-Weber. If it is Port-Weinstein in the area of the trigeminal nerve, especially if including the eye, you think of Sturge-Weber. If it is hemangioma, you think of the Phaces, Phaces syndrome. And the differentiation between them is not easy. And you need a specialist, you need a dermatologist. يا ريت الدكتور أشرف حمزة كان معنا النهارده. He was with us last meeting and he enriched our discussion. So we'll go through this case. Per maternal report, a faint lesion was, so this lesion was present at birth. And you remember last time when we discussed the skin rash in a newborn, and I asked you, Dr. Manal, to describe how to describe a skin rash. One of the points that maybe no other dermatologist or physician care about except in the newborn period is when the rash or the lesion started to present. Because when it presents at birth, the differential will be different when it presents later on. And depending on later on in hours, days, weeks, you are going to have a totally different differential. Okay? So this lesion was present at birth and started to deepen in color over the first hours of life. So it's changing. Okay. Baby has a reassuring neurological exam and started on breastfeeding with no difficulty. And they did MRI, which revealed left-sided cerebellar hypoplasia. So yes, the baby had cerebellar hypoplasia and vermis hypoplasia, and asymmetric enlargement of the left Meckel's cave. I don't know what is Meckel's cave, but you can review your anatomy classes. Ophthalmic evaluation is important. Finds no abnormalities of the left eye, aside from extension of the facial lesion of the eye. So there is no glaucoma. So now we are a little bit ruling out a little bit Sturge-Weber, but let us wait and see. So there is a cerebellar abnormality. There is this lesion, reassuring neurological exam, but the baby has other problems. The baby had also ASD, foramen secundum ASD, so had some issues with the heart. Okay, had some heart problems. That's why they had to consult genetics. After consulting the ophthalmology, the cardiology, of course, the dermatology, they consulted genetics. And as I mentioned before, most of the diseases now are diagnosed by genetics. And to have a good NICU, you should have affiliation, attachment with a very expert geneticist and very highly qualified, up-to-date genetics lab. Otherwise, you will miss the diagnosis of many problems. And this is the head ultrasound of this baby. Sorry, no, it's not ultrasound. Ultrasound. Asymmetric left cerebellar size and extra axial space too much because of cerebellar atrophy or hypoplasia. This is a CT. On day 3, demonstrating left-sided cerebellar hemispheric hypoplasia, confirming the ultrasound findings, which is ipsilateral to the patient. So on the same lesion, on the same side of the lesion, there is cerebellar hypoplasia. And so we have skin lesion, we have minor heart problem, defect, and cerebellar hypoplasia on the ipsilateral side. So after 3 weeks of age, the patch has thickened and deepened in color. And the mild left eye swelling leading to decreased spontaneous opening started to improve. And this allowed them to use propranolol. And as we talked about treatment of hemangiomas, they thought it's a hemangioma, which may not be correct. I used propranolol, and usually we use it topical unless the site of the lesion is in a certain area where you have to use surgery or laser or some other treatment modalities. CT, angiogram, they did angiogram, identifies no additional vascular anomalies. No additional vascular anomalies of the head and neck, which goes more with, if this positive, if they found vascular anomalies, this goes more with Sturge-Weber. So, discussion. What is the differential diagnosis? So, the differential diagnosis for this patch, it's either capillary malformation, which we call port wine stain, which goes with the Sturge-Weber, or it is infantile hemangioma, which goes with the PHACES. So these are the two differential diagnoses based on the two differential diagnoses of the patch. So what is in the, we know about Sturge-Weber, it is hemangioma, it is port-wine stain in the trigeminal area affecting the eye. There might be cataract affecting the brain and the vasculature of the brain, and there might be neurological manifestation. We don't have this in this case. Or Phaces, PHACES, where we have posterior fossa malformation, which is cerebellar malformation. We have this in this case. Hemangioma, so this patch might be hemangioma. Arterial anomalies, we don't have this intracranial. The angiography was negative. Coarctation of the aorta, no. Cardiac defects, yes. Eye abnormalities, no, we don't have this. So they were confused which of which, but it's more in the side of PHACES. After discussion among multiple experts, including dermatology and neurology, she was diagnosed with PHACES. So they thought it's more PHACES than Sturge-Weber, but this is not an easy differentiation. And they had to go to the expert dermatologist to tell them what's going on. The two can appear similar in life. A fully formed red patch at birth favors capillary malformation. Capillary malformation. So yeah, a fully formed red patch at birth favors capillary malformation. So port-wine stain. This is one of the ongoing lessons. Darkening and thickening over time suggests hemangioma. Yeah, I know it's not an easy case. The condition, infantile hemangiomas are the most common, benign, occurring in 5%. So it is infantile hemangioma, causes with PHACES. And this is the description. I will not go into these details. So Phaces is speculated to be a vascular neoplasm caused by cephalic neuroectodermal defects in the embryogenesis and overexpression of vascular growth factors. The diagnostic criteria for Phaces include facial hemangioma, as in this case, more than 5 centimeters, one major or two minor criteria involving abnormalities from the following categories include, so one major or two minor of the following. And he didn't mention which is minor and which is major. Cerebrovascular lesion, brain structure, cardiovascular, ocular, and midline anomalies. So this baby has, you can clinically diagnose Phaces in this case. What do they do for this baby could have neurologic abnormalities in the future because of the cerebellar issue. And when you have posterior fossa problems, you could have the Dandy-Walker malformation. The Dandy-Walker malformation is the posterior fossa is not well developed, and there is down displacement of the brain, and this can cause hydrocephalus. So this baby needs follow-up because this baby could develop hydrocephalus. Okay. I think I have to stop at this point. Yeah, the management is just conservative, close neurologic surveillance, look for seizures, headaches, movement disorders, hearing abnormalities, hydrocephalus. So just follow up. And they recommend using systemic treatment with propranolol. Systemic. I don't know why they preferred it on a topical. I don't know. But this is what the dermatologist suggested. Systemic treatment with propranolol is the recommended treatment. The patient course successfully initiates propranolol with associated episodes of mild hypoglycemia that resolves. Yes, because beta blockers can cause hypoglycemia with slower dose increase. She is currently meeting developmental milestones. So the baby was doing okay. Any questions, suggestions, lessons? The trajectory of a facial lesion over the first week of life can be pivotal in distinguishing hemangiomas from capillary malformations. Capillary malformation like port2 stain. Hemangioma like in this case. Hemangiomas goes more with Phaces. Port2 stain goes more with Sturge-Weber. And okay. Now we are 1 hour and 15 minutes. We can present another case if you are interested. If not, we can stop at this point. What do you need? Another case or we can stop? It's up to you. I selected these cases because they will, they are within the same scope of the last lecture of newborn skin rash. Let me see the chats. More, another case, more, another case. Okay, okay.
ماشي يا
This
دكتور، ممكن نعمل فول سكرين بس بعد إذن حضرتك؟
حاضر. This is another case. And it is easy because we discussed blueberry muffin hundreds of times. But the diagnosis is surprising, and because not all the criteria confirmed one diagnosis, but it was diagnosed with skin biopsy. So this is a female, 37-weeker. Mom was gravid at 2 para 1 C-section. She presented at birth with hepatosplenomegaly and diffuse rash. And the rash was described as blueberry muffin rash. It consists of petechiae, macules, variable size and on the legs, back, arms, and head, violaceous, firm, smooth nodules throughout the back, abdomen, and extremities, with the largest on the left posterior elbow and left knee. This is the rash presenting at birth. Okay. The blueberry muffin and more rashes. Petechiae, macules, variable sizes, nodules, it was polymorphic, generalized, not localized, blueberry muffin rash. So what do you mean by blueberry muffin? Numerous, scattered, non-blanching, papular or nodular, blue to purple purpura in a neonate. This is the description of the blueberry muffin. Okay, this on day 1 of life, the rash was there, and as we see here, on day 6, the rash started to have some resolution, some spontaneous regression. If you compare this picture to this picture, there is some spontaneous regression and resolution, which goes in favor of the final diagnosis. Okay? The history, mom had polyhydramnios. She had flu-like illness a couple of weeks prior to delivery, which might make you think of possible congenital infection or viral infection affecting the mother that caused congenital infection. But this is part of the history, may or may not be affecting the baby. Perinatal laboratory evaluation was reassuring with rubella immune status negative, HIV negative, syphilis negative, GBS negative, hepatitis B negative, chlamydia negative, gonorrhea negative. So most of the, I think we can rule out torches in this condition. Laboratory evaluation on admission was significant for pancytopenia. There was pancytopenia. This is a puzzle now. Why this baby had severe bone marrow suppression? What are the conditions when we can have fetal bone marrow suppression? We just discussed congenital syphilis as one of them. And it presented with anemia. It can cause also thrombocytopenia and neutropenia. So what are other conditions? Congenital neuroblastoma. And I will not, parvovirus B19, but it mostly causes anemia. No, it does not cause pancytopenia. The torches, all the torches can cause pancytopenia. So absolute neutrophil count 0, coagulopathy, unconjugated hyperbilirubinemia, and elevated AST, ferritin, uric acid, and lactate dehydrogenase. So there was affection of the liver. Coagulopathy, unconjugated hyperbilirubinemia, and elevated AST, and ferritin, and uric acid, and lactate dehydrogenase. So there was affection of the liver. Hepatosplenomegaly. Infectious testing was obtained and included. They did repeat the test for torches again because of this pancytopenia. They did test for HIV, toxoplasma, syphilis, rubella, PCR for CMV, parvovirus, herpes virus 1 and 2, HIV, enterovirus, and they did all the panel. They did head ultrasound looking for, if you have congenital infection, what could you have in, what are the findings you could have when you do head ultrasound or head CT or head MRI? The most important is calcifications, and the calcifications give you an idea, is it toxoplasmosis or CMP according to the pattern. They started ampangent and acyclovir like a routine to cover the baby, and they consulted hematology, oncology, and dermatology. So there is a diagnosis which we didn't mention. And I know pancytopenia is against this diagnosis, but for blueberry muffin, what else we could have? In addition to the torches, to the neuroblastoma, to the histiocytosis, Langerhans cell disease, what else? There is an important diagnosis which should not miss. Leukemia, yes. So congenital leukemia. What is the type of congenital leukemia? It is usually acute AML, monocytic leukemia. So let us look at the labs. The blood type was O positive, the Coombs test negative, white cell count was only 2,950, very low. Hemoglobin very low, 7. Hematocrit very low, 22. Platelets only 17. Redistribution width, it's not helpful here, 19.9. Mean corpuscular hemoglobin concentration is within normal. Absolute neutrophil count, 0. Absolute lymphocytic count, 2.92. PT was on the high side, coagulopathy. INR was, I don't see the, was 1.7. Yes, was more or less within range. PTT prolonged, fibrinogen low, liver function impaired. Total bilirubin 6.3, mostly, and the conjugated was high, 0.8. It should be less than 20% or less than, I believe, 0.5. ALT, it's okay. AST was high. Ferritin sky high. Uric acid is 8 high. LDH high. So based on these labs, differential might change. And there is a very important differential diagnosis. When you see such a horrible blood count, especially with pancytopenia, you think of a syndrome, erythrodys, whatever, that occurs in Down syndrome. So look at the baby and be careful this baby is not downing, because the Down syndrome babies could present with the abnormal hematologic findings. So you should rule out Down syndrome. Differential. The differential diagnosis of blueberry muffin type rash is broad, as we said. It includes infection, mostly congenital infection, blood dyscrasias, mostly leukemia, neuroblastoma. Neuroblastoma is malignancy. Malignancies like neuroblastoma. Because these observed skin lesions can be caused by dermal erythropoiesis. Yes, what is, when you do biopsy, what are the possible findings in these conditions? Erythropoiesis, extramedullary erythropoiesis, because of bone marrow suppression, vasculopathy or vascular malformation, or neoplastic dermal infiltration if you have neuroblastoma or leukemia. And this is how they diagnosed this case. They did skin biopsy. And they ruled out torch, which was very high possibility because of the pancytopenia, but they ruled it out. And then they did skin biopsy, which was the clue to this case, and they diagnosed as AML. This was the final diagnosis. And the issue with AML is that it could have spontaneous regression, the same as what happens in neuroblastoma. But the issue is, are we going to treat or we are not going to treat? Are we going to just observe the baby? This should be done in consultation with the hematologist, with the oncologist, and with the geneticist, and with the dermatologist. So they found, when they did genetic study, they found that it revealed KMT2A lysine specific methyl transferase 2A. I am reading as if I'm reading hieroglyphics. Rearrangement consisting with neonatal acute myeloid leukemia. So it was the biopsy, the genetic evaluation, and when they found this abnormalities in blood, they sent for FISH to rule out Down syndrome, as I told you. So I'm not going to go into the details of the AML, but the treatment will be more or less the same as in older children, keeping in mind that it might regress on its own. So you have to decide from the get-go, are you going to treat or not, based on the baby condition. If the baby condition is stable, the baby is improving, the lesions are getting better, hepatosplenomegaly is improving, you may not need to treat. If you need to treat, you will use the same protocol in the in older children, which is, I will just mention the name of the medications. Yeah, they did also bone marrow. They did bone marrow biopsy and bone marrow aspiration to confirm the diagnosis and to confirm how bad is the condition. So, oh yes, they used anthracycline, cytarabine-based chemotherapy, and in addition, they used gemtuzumab and ozogamicin and an anti-CD33 humanized antibody conjugate with cytotoxic antibody. And the most recent treatment, which I might discuss, I'll give you a lecture one day about the bone, the cord blood cells, and the use of cord blood cells, including the stem cells, in treatment of many conditions in the newborn, including the leukemia. They can use hematopoietic stem cell transplant. I will stop at this point. And any questions, any comment, any suggestions? Dr. Marwa, next Saturday, inshallah, Abdurrahman is going to talk about bleeding, GI bleeding in the newborn baby.
إن شاء الله. إن شاء الله.
Abdurrahman, are you with us?
هو كان موجود.
Yeah, I just need to get your presentation as early as possible. And I mean by as early as possible, at least 3 days before Saturday. Okay, thank you very much. And
معلش
see you.
دكتور إيهاب، عندي سؤال بس ما عنديش المعلومة، بس عايزة أسأل حضرتك عليه.
اتفضلي.
الديرمال إريثروبويسيس، أنا بالنسبة لي المصطلح ده يعني ما أعرفش عنه غير إن هو ممكن يحصل نورمال فاريانت في نيونيت
Normal variant؟
ممكن أستنى عليه إن هو
لا استني بس، طولي بالك. لا مين قال ان النورمال فاريانت؟ What is the source of this piece of information؟
يعني ممكن أبص أقول لحضرتك قريتها فين، بس أنا مش عارفة ده رونج كونسبت، بس أنا مش عارفة إيه الديرمال إريثروبويسيس أصلا يعني.
extramedullary hematopoiesis. When you have a bone marrow، فاكرين حالات الثلاسيميا والحاجات دي كانوا بيبقى عندهم ايه extramedullary hematopoiesis because the bone marrow does not form enough normal hemoglobin. فدول those have severe bone marrow suppression, and mostly it is in case of torches, but it could be in other conditions as we discussed. So the body tries to compensate for the bone marrow failure by forming blood cells outside the bone marrow. So part of this is the skin, and that's why there is the blueberry muffin rash, which has extramedullary hematopoiesis, erythropoiesis, coagulopathy, vascular abnormalities, and if there is malignancy, there will be malignancies. So I don't think that extramedullary erythropoiesis is a transient newborn, normal newborn issue at all. I don't.
ممكن حضرتك تسمح لي ابعت لحضرتك على الفيسبوك حاجه من ميدسكيب؟
حاجة من ايه؟
ميدسكيب
يعني ايه
بالنسبه للديرما اريثروبويسيس، يعني هو كاتب ان ممكن يبقى نورمال فارينت. انا بس المعلومه مش عارفه دي صح ولا غلط.
No, I don't. This is absolutely not correct. No way. I have never came across this piece of information at all. واحنا دلوقتي we discussed in brief the blueberry muffin and the extramedullary hematopoiesis. We didn't see it could be a normal variant, or it's not transient, like transient melanosis or erythema toxicum. No, I'm sorry, no. You can send it to me, I don't mind, or on WhatsApp, I don't mind, but let me, I will make a deep search for that, and I will give you the answer, and if I'm not correct, I will let you know. Okay?
Thank you Prof.
Thank you very much.
دكتور
نعم.
عبد الرحمن معانا. دكتور عبد الرحمن معانا يا دكتور.
ازيك يا دكتور عبد الرحمن؟ Are you ready or not yet? Okay.
ايوه دكتور، انا موجود مع حضرتك بس.
Whenever you're ready, Dr. Abdurrahman, send me your presentation and we can discuss it. You have a limited, well-defined article, which is not difficult to deal with. So just send it to me like 3 days before you, just to review it, and if there is some change.
ان شاء الله ماكسيمم باي ماندي يا دكتور تكون عندك ان شاء الله.
إن شاء الله حبيبي. Okay, thank you very much and see you next Saturday إن شاء الله.
Okay.
إن شاء الله. شكرا.
مع السلامة.